Hi everyone, my name is Lily Kidd, and today I will be presenting the discovery and understanding of Para-Bombay. Para-Bombay phenotype is a rare blood group variant where there is little to no H antigen on the red blood cells, but may be present in body secretions. Bombay patients have no H antigen anywhere and make strong anti-H, while Para-Bombay patients are more variable. They may lack H on red cells but still have it in secretions like their saliva, making their blood typing results and transfusion needs much less predictable. Bombay has an inactive FUT1 and FUT2 gene, while Para-Bombay has an inactive FUT1 gene but active FUT2 gene. H antigen is the foundation or precursor for A and B antigen formation. Without it, A and B antigens can't form, which is exactly what makes Para-Bombay so unique and difficult to detect. Understanding the H antigen is essential because Para-Bombay individuals lack or have a very little H antigen on the red blood cells. Without H antigen, A and B antigens cannot be properly expressed. However, due to an active secretor gene, H antigen may still be found in secretions. Both Bombay and Para-Bombay lack the H antigen on red cells due to the FUT1 mutations, but Para-Bombay individuals still have a working FUT2 gene, allowing H antigen in secretions and causing weaker but more variable blood typing results. If you're like me and wondering, well, what does the forward and reverse typing look like on a Para-Bombay patient? It's very similar to regular Bombay, but with a few differences. Our forward typing shows O or possibly a weak A or B or AB antigen, and that is very unique because group O and regular Bombay patients have no A or B expression for the antigens. The reverse typing is positive for anti-A and anti-B and a possible weak anti-H. The secretor status is positive for weaker abnormalities and negative for more Bombay-like. Antibody panels show reactions with all. Here is a detailed chart comparing the differences between Group O, Bombay, and Para-Bombay when it comes to how they present to a blood banker. For the H antigen on the red cells, for Group O, it is present, Bombay, it is absent, Para-Bombay, it is absent or weak. For the A and B antigens, it is absent on both Group O and Bombay and variable for the Para-Bombay because they can still express the A and B antigens. For secretor status, it is variable with Group O, and Bombay shows usually not a non-secretor, and then for Para-Bombay, it is often secretor. H in secretions is present in Group O if they are a secretor, absent in Bombay because they lack both of the FUT genes, and present in Para-Bombay if they are a secretor. I want to note that that the variability with Para-Bombay because it has the inactive FUT1 gene but active FUT2 gene, causing the slight reactivity due to its presence in bodily secretions. There is a big risk of misidentification when it comes to Para-Bombay because it can look like Group O in a regular forward and reverse typing and can lead to an unexpected cross-match incompatibility because of a possible production of anti-H. As a result of the production of the H antibody, the patient may require H-negative blood. Ensuring proper blood selection is not as straightforward as normal compatibility testing. Patients can tolerate certain units or react depending on the antibody strength. This is a very tedious and careful cross-matching and antibody workup. Para-Bombay often presents with unexpected forward and reverse typing mismatches. Recognizing it prevents incorrect reporting of the blood type and delays in transfusion. Once the patient has been identified with Para-Bombay phenotype, the technologist will have a better understanding of the tests that are needed to be performed. These tests include anti-H lectin, secretor studies, and advanced serological methods. Anti-H lectin is a plant-derived reagent. It specifically binds to the H antigen on red blood cells if present. How the blood bank uses this reagent is by adding patient 5% red blood cell suspension to a test tube. They add the reagent, centrifuge, and then observe for agglutination. Para-Bombay individuals will have weak or no agglutination due to the absence of the H antigen. The secretor testing determines if the patient has a functional FUT2 gene. It detects ABO or H substances in secretions. When collecting the saliva, it will need to be incubated in a boiling water bath for at least 10 minutes and centrifuged. The clear supernatant is what is used for testing. In Para-Bombay, there should be no agglutination in the saliva test. No agglutination means that they are a secretor, and agglutination means that they are a non-secretor. I have also attached in the corner the anti-H lectin testing procedure, and it also provides the secretor testing in that as well. Serologic testing can be difficult to perform due to inconsistencies with the results of a Para-Bombay patient. When trying to identify the discrepancies and the reactions on an antibody panel, it can become difficult for the technologist to find compatible units due to the rarity. Smaller blood banks may not even have all the resources for a procedure like this and will need to be performed in a reference laboratory. It is detrimental to perform a full antibody identification panel and test multiple donor units using the AHG cross-match method to ensure compatibility. If the patient has the H antibody, then the patient requires Bombay blood. If nothing is compatible, the blood banks may contact American Red Cross Rare Donor Services, or for us, we have the Kentucky Blood Center. When an emergency transfusion happens to a previously identified Para-Bombay patient, decision-making becomes very critical. There is no time for a full workup of donor and recipient compatibility. Say the patient has a weak anti-H, using Group O can be a safe option. It is important to remember that a donor unit of blood can contain more or less H antigen depending on the blood type. AB blood has less antigen while Group O has more antigens. If there was a Group O Para-Bombay recipient with a strong H antibody needing emergency blood, it is crucial to communicate and explain this situation to the physician for them to make the call if they want to give the blood or not. So now time for my case study. So I did have to look up this case study online because I've never experienced a Para-Bombay patient. Hopefully that doesn't happen very often, which I don't think it will. But this one, I linked the article at the bottom there where it says Para-Bombay case study. But this is a 25-year-old female, and she was admitted for anemia during pregnancy. She presented in the 22nd week of gestation. Her hemoglobin was 6.5 with no history of bleeding disorders, and she's on no medication. When performing her type and screen results, it showed she has O positive blood and no agglutination with anti-H. Reverse grouping shows agglutination with pooled A and B cells, but no agglutination with O cells. So what this looks like is a normal group O, but the no agglutination with H, with anti-H, shows that she has no H antigens. And then goes on to say, after checking the secretor status by Weiner's hemagglutination inhibition test, they found she had secretion of H substance in her saliva. In the article as well, it also shows different pictures for the reverse and forward typing. Our first picture here is their forward typing results, and you can see that there is no agglutination with the H antigen. In our reverse typing, it shows agglutination with A and B and no agglutination with O. And the hemagglutination inhibition test was performed in the control tube labeled as C, shows agglutination with a clear supernatant, while the test tube labeled as T shows no hemagglutination and represents our patient is a secretor. Para-Bombay is extremely rare, but the exact frequency is hard to determine due to the misclassification and specialized testing to confirm. It is found more commonly in South Asia, especially India, Southeast Asia, and certain parts of the Middle East, while there is lower prevalence in Europe, North America, and Africa. Para-Bombay is rare globally, but more concentrated in certain populations due to genetic inheritance patterns, and is often under-recognized because routine blood typing doesn't easily detect it. So now I have some questions for you all as a recap of everything that we've talked about. So question 1 is, why can't a patient with a Bombay phenotype receive group O blood even though they appear as O on the forward type? Question 2. If a patient types as group O but is incompatible with all O donor units, what additional tests should the blood bank perform next, and why? Question 3. What could happen if a Bombay phenotype patient is mistakenly transfused with standard group O blood? So this concludes my presentation on the discovery and understanding of Para-Bombay. If you would like, I've also included all of my references so you can go back and look through those if you want a deeper understanding, and I truly recommend the Blood Bank Guide. He goes into a very in-depth description about Para-Bombay and Bombay and everything to know about it. So thank you.